We started the previous lecture last Tuesday talking about intrapartum care. We know what are the stages of labor: first, second, third, fourth, how each one begins, how each one ends, and we learned already in the first and second stage what will be the frequency of auscultating the fetal heart, and we know that we have two methods to follow the fetal heart: either intermittent auscultation or continuous monitoring by CTG. We see that there are 4 places for delivery, and we know which one will be suitable for which case. We know what are the causes for transfer from the home to the unit, what are the indications, and this occurs at 10% of home delivery. How to choose intermittent auscultation, how to choose CTG, and what are the available options for labor analgesia. We said which one is the best, which one is most common. The difference between effect of meconium in first stage and effect of meconium in second stage. And we will use CTG with 4 hours between alert line and action line. And we stopped here. So now let's say that we have Mrs. X. Mrs. X is nulliparous. She is coming to the hospital in labor. Her cervix is dilated 5 centimeters. So she is already in established first stage of labor. How we will do follow-up for her? She is low-risk pregnancy. So we will use intermittent auscultation. وعليكم السلام شكيلة. So we will use intermittent auscultation as she is low-risk pregnancy. We are now in the first stage of labor. So we will do vaginal examination each 4 hours. Each 4 hours. What is your target? My target is each 4 hours there will be dilatation 2 centimeters. So she is now 5 centimeters. I want after 4 hours the cervix becomes at least 7 centimeters dilated. So each 4 hours I need 2 centimeter dilatation. This is the course of normal delivery. What if after 4 hours we examine the Mrs. X? Her cervix was 5 centimeters. I am expecting 7 centimeters. What if we found that her cervix dilatation is 6 centimeters only? So we have only 1 centimeter extra in these 4 hours. In this situation, I will suspect that there is delay in labor in Mrs. X. I will tell her, please, Mrs. X, you have somehow, we suspect that there is slow progress of labor, and we can offer you rupture of membrane. We used to examine you each 4 hours. As long as we suspect that there is delay, 4 hours will be too long. So we need to examine you after 2 hours. Okay, I accept. You can do rupture of membrane, and okay, you can do examination after 2 hours. After 2 hours, we found that we want, I said that in 4 hours, we want 2 centimeters. So in 2 hours, we need 1 centimeter. What if after these 2 hours we had only less than 1 centimeter? So less than 1 expected. Mrs. X is insisting to make us diagnose that she has delay in labor. So we have now diagnosed delay. How will we counsel her? We will tell her that you have sure now there is poor progress of labor. So please, if we didn't rupture the membrane before, if you refused before, we want to do rupture of membrane. What if the membrane is already ruptured? Then we can consider oxytocin. But if not ruptured yet, we can rupture the membrane and examine again after 2 hours. 2 hours, so you want 1 centimeter dilatation. If this didn't happen, we will counsel her about oxytocin, and we need to assess the condition well, abdominal examination, and to see the general condition of the woman and the general condition of the baby. Again, Mrs. X, nulliparous, 5 centimeter dilatation. Okay, admission, intermittent auscultation, examine after 4 hours. What do you want? I want additional 2 centimeters. If not achieved, suspect delay. And examine after 2 hours only, and counsel her that we need to do artificial amniotomy. If she accepts, okay, excellent. We will examine after 2 hours. What do you want? I want 1 centimeter extra. Achieved, okay. Not achieved, I am sure that there is delay. This is the second time that she doesn't achieve our target, so we are sure that there is delay. If the membrane is not ruptured, we will do rupture. If ruptured, consider oxytocin. So, in the routine care, in the first stage, we do PV each 4 hours. For women with delay in first stage, we examine after 2 hours when you suspect that there is delay. And we know that there is a rule. Once your ear hears oxytocin, you have to say, consider epidural or whatever, any method of pain relief, but of course, epidural is the best. Number 2, oxytocin equals CTG. Oxytocin is a dangerous drug. Oxytocin leads to reduction in uteroplacental blood flow. We know that in between contractions, blood reaches the baby, but during the contraction itself, blood is reduced. So if oxytocin led to increased frequency, increased amplitude of contractions, reduction in uteroplacental blood flow may occur, and fetal hypoxia may occur. That's why oxytocin equals CTG and pain relief. Okay, Mrs. X was nulliparous, and this is how to manage her. What about parous women? What about parous women? Parous women also, we will do examination for her each 4 hours, and my target 2 centimeters. But there is another consideration in parous women. Not only dilatation, also we need progress. So generally, management in nulliparous and multiparous is somehow similar in first stage of labor, because there will be variation in second stage of labor. But in first stage, we deal with them the same. Examination each 4 hours. If suspected delay, examine after 2 hours. My target is 4 centimeter, is 2 centimeter each 4 hours. When you suspect a delay, your target will be 1 centimeter each 2 hours. Okay, any question up till now? Okay, common questions in this part. You are asked about what will be the frequency of BV each 4 hours. What will be the frequency of intermittent auscultation in first stage? Somebody remembers? Intermittent auscultation in first stage. Each
15 minutes.
how many?
15 minutes after contraction for 1 minute.
1 minute.
So each how many minutes?
15
Every
minutes.
15 minutes.
15.
And at the end of contraction, we will auscultate for 1 whole minute.
So each 15 minutes we auscultate for 1 minute, and this should be done after the contraction. Why after the contraction? Somebody knows?
Because the chances of decelerations are more,
Excellent.
and that you can pick it up.
Excellent, Dr. Fawzia. To catch any decelerations. If there is late deceleration, I will hear that heart rate is slow after the contraction. And if I found that there is deceleration, I will ask for CTG for 20 minutes. If normal, return again to your intermittent auscultation. And don't forget, oxytocin, you have to counsel her before oxytocin that we need pain relief. Tell her that contractions will be stronger, the pain is expected to be more, and also tell her that we need CTG. Very important question, especially about auscultation.
Dr. Osama, I have a doubt.
Yes?
Dr. Osama, I have a doubt. See, like actually, you were telling about amniotomy. So after doing amniotomy, we have to just look for the color of the fluid and everything, and then we have to look for any cord prolapse, isn't it? That
Look for what?
cord prolapse.
Sure. Who's doing?
Any cords.
Yeah.
No, like actually, no. Here it says in the algorithm, like consider amniotomy if the membranes are intact, and then whether membranes rupture or not. Advise vaginal examination 2 hours later. So actually, we are supposed to, look for all these things, no?
You exclude the presence of cord prolapse at the same moment of rupture of membrane. You do rupture of membrane
Okay.
and feel by your finger, and you have to do this before rupture of membrane. Now you are doing BV, intending to do rupture of membrane. You have to feel at first if there is any pulsation of the cord just above the membrane.
Yeah.
If there is pulsation, don't do rupture of membrane. It's now a situation of cord presentation. Okay, and if you find that there is no cord all around, you can do rupture of membrane and again feel that there is no cord coming below the head.
Yes. Okay. Okay, thanks.
Okay, thank you. Okay,
Dr. Osama, what is telemetry?
What is what?
Telemetry.
Telemetry? What is the meaning of this?
Telemetry is online CTG. It's like CTG monitor, like you are in ICU, you are following all ECGs on a monitor. It's like a monitor, you are monitoring all CTGs in your department on one computer station. That's telemetry.
There are different variations of CTG. We have what's called computerized CTG, and we have what's called ST wave analysis. It's called STAN. It was a project that not only CTG to be done, Also, we do what's called ST wave analysis, but this project stopped. They found that it's difficult to be applied all over the country. That's why STAN project stopped, ST wave analysis. So now we use CTG. And of course, all monitors are connected to central computer, so you can visualize the result of all CTGs immediately, minute by minute. So what is routine now in UK? That either intermittent auscultation for low-risk pregnancies and this CTG for high-risk pregnancies, or if there is transient risk in low-risk pregnancy.
Doctor, sorry, Dr. Osama, but regarding the CTG, there is something like a wireless CTG that the lady can put it and mobilize at the same time without wire connected to the machine, or nothing like that?
Okay, it may be present, but it's not routine. What is routine now? The usual CTG, and it has two options, either external application or internal application. So there may be external transducer or internal transducer to be applied to the fetal scalp. So by any way, we have a transducer applied to the abdomen to measure the frequency of uterine contractions. Another transducer to measure fetal heart. It can be present on the abdomen from outside. What if the woman is obese or I can't hear from outside? This transducer can be applied through the vagina to the fetal scalp. And take care if you are going to do cesarean section for this woman, take care, sometimes you may forget the internal transducer. So you have to remove it before doing cesarean section. Okay, any other questions? Okay, very important, frequency of BV. What are you going to do if you suspect that there is delay? You need pain relief and CTG with oxytocin. Second stage of labor. Second stage also, it has two compartments. The first one, passive second stage. Second one, active second stage. What is the difference? In active second stage, the woman will feel involuntary urge to push. So there is involuntary bearing down. Actually, we don't diagnose or we don't search to diagnose passive second stage. We know that the woman is in second stage when we hear that she is doing involuntary bearing down. So we don't measure the first or the passive part of second stage of labor. I am doing BV, now she is 8 centimeters. Okay, after 1 hour or after 2 hours, we found that she is doing involuntary bearing down. So we know now that we are in active second stage of labor. This part, active second stage of labor, it may be absent in women with epidural analgesia. That's why we say that epidural analgesia leads to prolongation of second stage of labor. Why? Because this compartment will be absent. Why the woman does involuntary bearing down in routine delivery? She feels that the rectum is full. It's not full, but there is compression over the rectum by the fetal head. So she thinks that the rectum is full, she starts to do bearing down. This sensation is not present in epidural. All the area is incised. That's why there is prolongation of second stage. And this prolongation can lead to increased the need for instrumental delivery. During labor, at any time in first or second stage, if you apply CTG and you found that CTG is abnormal, what will be the next step? You have two options. Number one, scalp stimulation by your finger, and this is what you are going to do. The next step, if scalp stimulation didn't improve CTG, that you will do fetal blood sampling. So in the old guideline, if you find the pathological CTG, do fetal blood sampling. In the new guideline, before fetal blood sampling, try at first tactile stimulation of the scalp by your finger. If this led to acceleration, this baby is good. If no acceleration, do fetal blood sampling. This baby may be compromised. But notice that in some pathological CTGs, some types of abnormality, like what's called prolonged deep deceleration, there is no time for blood sampling. Deliver this baby immediately. If candidate for an instrumental, forceps or ventouse, do it. Not suitable, emergency cesarean section. So according to CTG abnormality, we can say what is the next step. How to reduce perineal trauma? Of course, we want to avoid perineal tear. How to avoid? Is there a need to do perineal massage? No. No perineal massage is done. What is beneficial to support the perineum during delivery of the head and to delay delivery of the head when crowning occurs by pressure over the vertex. So your right hand is supporting the perineum, your left hand pressing over the vertex and decreasing the progress of labor, because sudden distension of perineum can lead to tear. It's called hand-on technique. Hand-on technique, that you are supporting the perineum and decreasing the progress of delivery by your left hand by pressure over the vertex. Episiotomy is not routine, even if there is past history of third or fourth degree perineal tear. So, if your case has past history of third or fourth degree perineal tear, it's not routine to do episiotomy this pregnancy. And of course, she has the right to deliver vaginally, as long as there is no long-term morbidity after the previous third or fourth degree perineal tear. Second stage of labor. And in second stage, there will be difference between care for nulliparous and the care for parous women. Of course, parous women are expected to have faster progress than nulliparous. That's why you will find that time allowed for parous is less than time allowed for nulliparous women. Let's see how. Can you remind me? In first stage of labor, we do BV each how many hours?
4 hours.
4 hours. What is your target? How many centimeters?
2 hours.
Yeah. 2 cm.
2 centimeters in 4 hours.
Excellent. Here, in second stage of labor, I do examination each 1 hour. Each 1 hour. What is your target? I need progress and delivery, of course. What if after 1 hour, active second stage, the woman now is doing pushing involuntary for 1 hour and not delivered yet? I will tell her, please, madam, you are pushing for 1 hour and not delivered yet. We advise you to do amniotomy. If there is need for labor analgesia, okay, offer labor analgesia. Okay, so I will do amniotomy and reassess again. I will reassess again after 1 hour. And I expect that she will be delivered. So she is pushing for 1 hour. And I examine her after 1 hour after doing amniotomy, if she accepts, and I expect that she should have delivered. What if now she is pushing for 2 hours and no delivery yet? We are now talking about nulliparous. She is pushing for 2 hours and no delivery yet. I will tell her, madam, you have delay in second stage. So what we are going to do, we will re-examine after short interval, each 15 to 30 minutes. For how many hours again? 1 hour. So pushing for 1 hour. I did amniotomy and examine after 1 hour. Up till now, 2 hours. After this second hour, I have diagnosis of delay. I will do examination each 15 minutes. For what? For 1 hour additional. The decision of oxytocin in second stage of labor is not that easy. It's difficult that a woman has good progress in first stage without oxytocin, and in the second stage there is dystocia. This is difficult. But anyway, if he told you that there is prolonged second stage, the baby is still okay. And of course, once I said that there is prolonged second stage, I need CTG. I have now abnormality. And he told you that the contractions are weak or 2 contractions per 10 minutes. Consider oxytocin, of course. But better than oxytocin. If the case, she is now fully dilated, okay? And now you are sure that there is delay. If you can try instrumental delivery, do it. If instrumental is not suitable, you can do cesarean section. So up till now, in this nulliparous woman, pushing for 1 hour, amniotomy and examine again after 1 hour, now 2 hours. In the third hour, I will examine frequently, each 15 to 30 minutes. So now I have 3 hours for nulliparous woman. What about parous woman? I will suspect the delay after only 30 minutes. After 30 minutes, I will suspect the delay. And if 1 hour passed of involuntary pushing, I will diagnose delay. So I diagnosed delay in parous woman after 1 hour of active pushing, and diagnosed after 2 hours in nulliparous. So here, this is a difference. I diagnosed the delay after 2 hours for nulliparous, after only 1 hour in nulliparous, and the same management will be done. And always, if there is delay in second stage, consider instrumental if possible. But Dr. Osama, which instrument are we going to use? We have forceps and we have ventouse. I am not the one who will tell you which one to use. It depends upon your skills. Which one can you do better? And also, you can counsel the woman that we have two instruments. We have forceps, which can lead to trauma to your perineum and your vagina. We have ventouse, which can do trauma to your baby's scalp, edema, up to intracranial hemorrhage. So we have two instruments. The choice will be upon your preference and the woman's preference. If an instrumental is not suitable, for example, there is excessive caput or excessive molding, or the head is high above the level of ischial spine, this is not candidate for instrumental delivery, and there is delay, you can do cesarean section. And we will know more about instrumental delivery and types of instrumental delivery today, inshallah. Okay, take care of writing by your hand on the screen. Take care. What about third stage of labor? In third stage of labor, we want the placenta and the membranes to be delivered. We have two methods for management of third stage. Although according to the postpartum hemorrhage guideline, which was published December 2016, that we will try to recommend active management of third stage for all women. Why? Active management, the placenta will be delivered in shorter time, so less postpartum hemorrhage, less need for blood transfusion. Okay, so we have two methods, active management and passive management. What is the difference? We have active management and we have passive management. Okay, again, somebody is writing on the screen. I will stop writing. Okay. We have active management of third stage and we have passive management of third stage. Which one is better? Active. Why? Less bleeding, less blood transfusion, but more nausea, no problem. Passive management, less nausea, but more bleeding, more need for blood transfusion. The difference according to, are you going to give oxytocin or not? In active, I will give oxytocin, 10 units intramuscular. In passive, no oxytocin. The placenta will be delivered only by maternal effort, just by hair pushing. And this is the most important difference. Oxytocin will be given or not. Another difference, in active management, you will do cord traction, and we can call it gentle, controlled cord traction. In passive management, no cord traction. Also, cord clamping. In active management, you will do cord clamping between 1 and 5 minutes of delivery of baby. In passive management, cord clamping will be done after pulsation stops, so more delayed. So in active management, I will give oxytocin. I will do gentle controlled cord traction. I will do cord clamping after 1 minute and earlier than 5 minutes after delivery of baby. In passive management, no oxytocin, delayed cord clamping when pulsation stops, and no traction will be done. Which one is more recommended? Of course, active management. Okay, I did active management of third stage for 30 minutes and the placenta failed to be delivered. Problem, retain the placenta. I am doing passive management for 1 hour and the placenta is not delivered. Emergency, retain the placenta. And if you are doing passive management and the placenta is not delivered after 1 hour, start active management. Start active management. So I will give oxytocin intramuscular. I will start to do gentle controlled cord traction. Okay, what if after this the placenta is not delivered yet? Now this is retained placenta. I will consider manual removal of placenta, but take care. Manual removal of placenta needs pain relief. So you can offer epidural before manual removal of placenta. Number 2, manual removal of placenta will increase the risk of infection. So I will give antibiotic. In normal labor, we don't give antibiotic. But if you do manual delivery of placenta, or if you repair perineal tear, this is an indication to give antibiotic. So, in third stage, I will say that there is delay if 30 minutes active management or 1 hour passive management passed without delivery. What is the next step? Secure IV access. It's an emergency. If passive, I will revert to active management. If not delivered within 30 minutes, then I will consider manual delivery of placenta. And the manual delivery needs pain relief and needs also antibiotics. What if at any time in labor you can't auscultate fetal heart? For example, by intermittent auscultation, you don't find cardiac pulsation. What is the next step? Ultrasound. Don't say CTG. If you think that the fetal heart is not heard, next step is ultrasound, not CTG. I want to see if the baby is alive or not. In this picture here, we have the indications for CTG. Meconium. I need significant meconium in first stage and any meconium in second stage. Tachycardia, bradycardia, maternal fever, and the maternal fever at labor is an indication to give broad-spectrum antibiotics. And this broad-spectrum antibiotic should also be covering GPS, which is Streptococcus agalacti. Woman request oxytocin. Oxytocin is an indication for CTG. Fresh bleeding in labor, bleeding more than show. All are indications for CTG in addition to any risk pregnancy. Any risk pregnancy. Notice that women in whom CTG is applied, she can't deliver water birth, delivery in a bowl of water. This can't be offered for women with CTG. So if a woman with breech presentation who chose vaginal delivery, she's asking you to deliver water birth. Sorry, we can't. The CTG is applied to you. It's an electric instrument. We can't offer water birth. So if you can't auscultate fetal heart, don't do CTG. Go for ultrasound. Any risky pregnancy is an indication for CTG, previous cesarean section. So previous cesarean section and now trying to deliver her vaginally. What is the meaning of this? You can say by mic.
VBAC.
VBAC. Thank you. What is the success rate of VBAC?
75.
75 to 90%.
75 to 90.
Excellent. What if the previous cesarean section was due to dystocia? What will be success?
60%, 60 to 65.
60, 65. Excellent. What if this woman had also previous vaginal delivery? What will be success rate?
90%.
90%.
90%. Excellent.
Assalamu alaikum, Dr. Sama.
Wa alaikum
Sajila
assalam.
here.
Sajila, how are you?
Alhamdulillah. I just read one more question regarding VBAC. Somebody was asking, okay, what is the success of VBAC after spontaneous? And the second part was, what is the success after IOL?
After IOL, VBAC, if you use induction, okay, success rate will be lower. And it's better not to do induction. But anyway,
there were percentages. So we have to choose from the percentages.
Okay, what were the options? And tell me if this woman has delivered vaginally before or not.
Yeah, that was in
I
an
think
incomplete
63%.
question.
63% from your previous lecture.
61?
If IOL and VBAC.
If you are
That's 63% is combination of, no, that is 40%, combination of 4. That is the
if contracted pelvis,
IUL, state, BMI high.
multiple factors. It will be 40.
Yeah, multiple factors, that is 40. But
Yes.
Only IUL, I am not sure because I didn't read anywhere alone.
I think, if I'm not wrong, induction of labor is 63%
It
success.
will be not far away,
And
75. By any way, it will be vaginal after cesarean section. Okay, as long as there was previous no previous vaginal delivery to change the number. Anyway, it will be not far away from 75. So, induced or spontaneous, as long as there was previous dystocia in previous cesarean section and previous vaginal delivery, because these are the factors that will affect the numbers. It will be near to 75. So if there is 70, okay, 70 will be a good number. Okay. In this part, this is about interpretation of CTG, and this will be explained more in the coming slides. So don't care for this part. It will be repeated again. Again, any risk pregnancy, you will do CTG. Diabetes, induction of labor, prolonged rupture of membrane, past date, preeclampsia, antepartum hemorrhage, any maternal disease, growth restriction, prematurity, oligohydramnios, abnormal Doppler, multiple pregnancy, breech presentation, any high-risk pregnancy, you will apply CTG. Okay, there are some factors you need to modify if there is abnormal CTG. Correct the woman position. The best position while doing CTG is left lateral. So if she is supine, no. Shift to left lateral position. If she is hypotensive, give her fluids. If she is feverish, give antipyretic. If there is oxytocin, you can slow or stop oxytocin. These factors, when corrected, they can improve CTG results. And if you apply oxytocin, we have to apply CTG. My target to have 3 to 5 contractions each 10 minutes. If there is abnormality while applying oxytocin, stop oxytocin or at least slow down the oxytocin. Okay, we said if there is abnormal CTG, what is the next step?
Scalp stimulation.
Excellent. Scalp stimulation. What if no acceleration occurred?
Fetal blood sampling.
Blood sampling.
Blood sampling.
Blood sampling.
And we saw the previous lecture, a video about how fetal blood sampling is done. At the end, you will have one or more capillary tube containing fetal blood that you will send them to have analysis for pH or serum lactate. And I am afraid that the result will be acidosis, because acidosis, so this baby is hypoxic, this baby is in danger, I have to deliver. So what will be the result of fetal blood sampling? The result either normal pH, borderline, or abnormal pH. Abnormal means one word, delivery. The common mistake that when we have a question in the exam asking about dystocia and CTG is pathological, blood sample showed acidosis, we will choose emergency cesarean section. Common mistake. The next step is deliver now, whatever the method is. You can do instrumental, and actually it will be more fast than cesarean section. So instrumental will be better if possible. If possible. He will give you some parameters. For example, he will tell you that there is caput 3+, there is molding 3+. Okay, there is no rule for instrumental delivery. It will be emergency cesarean section. If he told you that the head is +2 station, mild caput, mild molding, he is directing me towards instrumental birth. So abnormal CTG, abnormal blood sample means delivery, better by instrumental. What if blood sample is normal? Good news, but take care, if your CTG still pathological, I will repeat again blood sample after 1 hour. And this new blood sample may also show that no acidosis or borderline or acidosis. So if blood sample is normal and CTG still pathological, I will repeat again after 1 hour. So what if blood sample is borderline? 21, 22, 23, 24. If borderline, I will repeat again blood sample after 30 minutes only. And according to the new result, I will see if the new result is normal or borderline or abnormal. So 7.20, excellent. 21, 22, 23, 24, borderline. 25, normal. So 7.22, acidosis 20, 7.20, acidosis 21, 22, 23, 24, borderline. 7.25 and higher, excellent. Abnormal, delivery, instrumental or cesarean section. Borderline or normal, you have to wait. If CTG is still pathological, You can repeat blood sample after 30 minutes if it was borderline, or after 1 hour if it was normal. The problem that some cases after the second blood sample still borderline. So I can't reach a decision. I can't say this baby is good or this baby is hypoxic. So what to do? Am I going to do third time blood sample? This can happen, but this needs consultant advice. So if we reach to that borderline, second time borderline, I need consultant decision if I will do again blood sample or not. And the consultant will look at the full situation, what are risk factors in this woman, and so on. Any question about fetal blood sampling? In fetal blood sampling, from where we are going to take the blood sample? Somebody can tell me?
Fetal scalp.
Fetal scalp, excellent. Fetal scalp, excellent. So there are contraindications for blood sampling. For example, prematurity. Baby less than 34 weeks, the coagulation factors are not developed yet. Severe bleeding may occur if you do puncture to the premature baby scalp. Also, if there is viral infection to the mother, hepatitis B, hepatitis C, herpes. Also, non-vertex presentation, you can't take blood sample from the baby's face. You can't do this. And also, if the situation is critical, for example, the case with prolonged deceleration, there is no rule for blood sample. This woman should be delivered. No rule for blood sample. Okay, any question about blood sample? Take care that we do fetal blood sample while the woman is in left lateral position. We don't do it while she is supine. We do it while the woman is in left lateral position. Okay, any questions so far?
Dr. Osama, please.
Yes.
Long deceleration is of 3 minutes.
Yes.
But again, on 3 minutes, they say that do the conservative management and if persistent bradycardia for 9 minutes. So where we have to take the action?
Look, conservative management will be done in all situations. However, non-reassuring CTG, I will do these expectant measures. Also, conservative measures. Also, in pathological CTG, also I will do expectant measures or these conservative measures, plus scalp stimulation. So, in any bad situation, you will do these expectant measures. Put the woman on the side. If hypovolemic, give fluids. If feverish, give paracetamol. If oxytocin is applied, slow down oxytocin or stop oxytocin. These rules are present in every bad situation. But there is another more important rule. If you have pathological CTG, you need scalp stimulation.
Okay.
The rule of prolonged deceleration. And we will see a picture for this. If this prolonged deceleration is prolonged more than 3 minutes, take care. It's an urgent situation. This woman should be delivered. At 3 minutes, I will call for help. At 6 minutes, the theater will be prepared for delivery either in instrumental or cesarean section. At 9 minutes, the baby will be delivered. At 12 minutes, the baby will be in the hand of the neonatologist for resuscitation.
Sorry, Dr. Osama, can you just repeat from 3 minutes to 12 minutes once again? Thank you.
At 3 minutes, you have now an emergency call for help.
Yeah.
At 6 minutes, the theater and the place and the woman will be ready for delivery. And you are looking at the CTG, which is maybe still pathological. If improved, okay. We now improved.
Yeah.
Still pathological. At 9 minutes, you will deliver. At 12 minutes, the baby will be in the hand of the neonatologist for resuscitation. So you will deliver at 9 minutes. Okay? And there is no rule for fetal blood sample in this situation. No rule.
Okay, means if more than 3 minutes, so we'll not go for fetal blood sampling.
No.
Only
No fetal blood sampling at all.
Yes, more than 3 minutes, it's deceleration. It's a specific critical situation.
Okay, so either to look for conservative management like maternal hypotension, position and all that, and to correct it, and meanwhile call for help, and then if not corrected by 9 minutes, baby should be out.
Yes.
Okay. Because very confusing.
Very confusing, and you do it every day and slips your mind again.
Not confusing at all. You will diagnose prolonged deceleration after 3 minutes. Call for help at 6 minutes. The woman, the team, the theater should be ready. At 9 minutes, you can apply your forceps or apply your ventouse or start your cesarean section. At 12 minutes, the baby is resuscitated by the neonatologist.
Yeah, and Dr. Sama, if, for example, she's not in the second stage, she's in first stage and she still can have this kind of a decel, prolonged decel,
So
then that means...
So
then obviously cesarean. Yeah.
No, obvious cesarean, okay, we all of us know, but when?
When what?
Then if the same...
At 9 minutes.
You have in first stage of labor.
Yeah.
For example, 6 centimeter dilatation.
Yeah.
You found the fetal heart rate was 120. Suddenly, it dropped to 80. And still persistent like this, 3 minutes. Oh, this is the situation. Start your emergency, call for help, prepare everything. At 9 minutes, if the situation is still persistent, I started already my skin incision for cesarean section.
All right.
Yes, because difficulty arises between the choices of instrumental delivery or the cesarean section.
Look,
like for me,
always you will ask yourself, is instrumental delivery possible for this woman? Is she fully dilated? Fully dilated 10 centimeter, not 9 centimeter. 9 centimeter cesarean section. 10 centimeter dilated, no severe caput, no severe molding, no severe contracted pelvis. Okay, this case, and the head is below ischial spine, this case is suitable for instrumental. If any one of these factors is absent, cesarean section.
Yes. Yeah, after full dilatation, I am getting confused always.
Yeah.
Before full dilatation, it will be cesarean section. After full dilatation, try at first to apply instrumental. Okay, because cesarean section in fully dilated cervix is a miserable condition.
Yes.
Clinical.
Yeah, but Dr. Osama, one thing that remains that at 3 minutes, we start call for help.
Yes.
And we start moving and everything, and 6 minutes does not matter in the first stage of the labor. By 9 minutes, whatever is first stage or second stage, we have to start our cesarean section.
But if she is fully dilated?
No. Of course, fully dilated, we'll attempt for for the vaginal delivery.
At minute number 9, deliver the baby by whatever possible method. If she is
Okay.
dilated,
Okay.
and we have the criteria of instrumental, apply instrumental. It will be better than cesarean section. But if she, if we
Here
are,
they are confusing actually, Dr. Osama, that they are giving different options. Then again, we are getting confused by for selection of instruments. Like the baby is okay, no caput, no molding. Then you will go for forceps or ventouse and like this type of confusing situation.
This is usually a very confusing question.
And also they are giving chance like instrumental delivery in the labor room or instrumental delivery in theater.
Okay, theater, there are those 4 factors, obesity and all those. But for nothing is there, you are delivering in the labor room, then if caput, okay, we understand that we cannot apply vacuum. But
look,
if there is no caput,
this point is not a point of recommendation. It's a point of your clinical sense. What I mean by this, if he gave you all parameters are okay, the head is low and no caput, no molding, he is telling you, please do instrumental at the labor room.
yes,
He told you that the head is at the level of ischial spine or just below ischial spine, and moderate caput, moderate molding. Will it be easy instrumental? No, it will not be easy. And the failure may occur. So I will do it at the theater because I expect I may need cesarean section.
Yes.
So he will direct you towards easy instrumental, so in labor ward, okay. Or he will direct you towards difficult instrumental, it will be in the theater. Or he will direct you towards not possible instrumental, so it will be cesarean section.
Okay. Like it headed +3 and no caput, no molding. Okay, prolonged bradycardia. Now you are going to decide between forceps or the vacuum. So what you are going to apply? Outlet forceps or vacuum? Then what we have?
At first, here instrumental at labor ward.
Yes.
In clinical, which one will you use according to which one you can practice better, and the woman's choice. She can choose. I don't want something to hurt my baby, and no problem to hurt me. So we will apply a forceps. Okay, but anyway, I think the decision at last returns to your sensation about the scenario, but take care that if we compare between forceps and ventouse, forceps is more successful.
Yeah.
Failure,
less time.
Failure rate with forceps is less.
Yes.
Also, forceps is more rapid than ventouse. So if the situation is critical and you want rapid delivery, apply forceps. If everything is okay, everything is smooth, the head is near, it's a good case to apply ventouse. And we have Kiwi ventouse, which is very easy to apply, and we will see video about application of Kiwi today.
Yes, we are using practically here. Then again, sorry, we are taking so much time, Dr. Osama, because a lot of questions came in my exam. This mid-cavity instruments, now they have started again. So, I don't know where to select mid-cavity.
We have 3 types of instrumental delivery. Okay, we have high, mid, low, and out. High is absolutely contraindicated, in which above the level of ischial spine. While mid, low, and outlet, they can be used.
Yes.
Okay.
Outlet and low also we can make out because we are using so much, but this mid cavity is problem.
Of course, it's difficult. It needs high skillful hands.
Yeah. No, to choose the option in the exam, like mid cavity, one is, I know that you have to choose in the theater.
Mid cavity will be the theater, yes.
Yeah, in the theater because failure. Then sometimes they are giving BMI also. So obese patient and mid cavity selection, then we'll move the theater. And then again, now to apply mid cavity or to directly proceed for cesarean, we are confused.
Mid cavity you can apply, but it will be in the theater.
Yeah.
And the failure rate will be higher than low or outlet. And in this situation, take written consent from the woman. In difficult instrumental, take written consent. In easy instrumental, verbal is sufficient.
Yeah.
We said that we have two types of.
Actually, sometimes scenario is very clear, you can select easily, but sometimes very confusing also.
Yeah, most of the time very confusing. Most of the time confusing, all these intrapartum EMQs.
Management. Because our teachers, most of them are having UK experience, and they used to say that they are more confident in forceps, and they are using also when I was there in Pakistan. But nowadays, I don't know what they are preferring in UK.
Okay.
Okay.
We said that we have two types of management of third stage. Active management, passive management. What is the difference? Oxytocin. Second difference, timing of cord clamping. The third one, will you do cord traction or not? In active management, I will give oxytocin 10 units intramuscular. I will do cord clamping after 1 minute. And I will do controlled cord traction. In physiological, I will not do cord traction. And there will be cord clamping when pulsation stops and no oxytocin. What is the outcome? In active management, less bleeding, less blood transfusion, but more nausea. In passive management, more bleeding, more blood transfusion, and less nausea. And you can say that complications are double in physiological management. How to decrease anal sphincter injury. These points can come in the exam. Warm compression helps. Hand-on technique helps. When crowning occurs, tell the woman not to push. When crowning occurs, we need to slow the progress of delivery of head. So, by your left hand, you will delay the progress of delivery of head, and you will ask the woman to stop pushing. We don't want sudden distension of the vulva. Episiotomy only if indicated, and we know that even if the case has previous obstetric anal sphincter injury, episiotomy is not routine in the next delivery. And if you are going to do episiotomy, it's very important that now the angle of mediolateral episiotomy is 60 degrees, not 45. In the past, it was 45. Now it's 60-degree angle, 60 degree, to decrease injury to anal sphincter. Now we will learn how to interpret CTG. We know now what are the indications of CTG. When we try to interpret CTG, there are multiple points that we will look at. Number one, we want to see what is the basal heart rate. What is the basal heart rate? Number two, we want to see if there are accelerations or decelerations. Number three, we want to look at what's called variability. And number four, we want to look at if there are contractions or not. Somebody didn't practice CTG at all, Okay, if you didn't practice CTG at all, you can write yes on the screen. If somebody didn't practice CTG at all, if somebody doesn't know the basics of CTG, I want to do snowballing. Somebody doesn't know CTG at all?
Sir, myself, Dr. Sadika.
Yes, Dr. Sadika, how are you?
Yes, Alhamdulillah, good doctor. Yeah, the place where I'm practicing, they don't often use CTG, so I'm not very much well versed with CTG.
No problem. You will be clever in CTG today, inshallah.
Inshallah. Okay, thank you, doctor.
Sorry, Dr. Osama, one doubt.
You are always
in FBS.
Okay.
Actually, doctor, in fetal blood sampling, that we will repeat the FBS after 1 hour, but if the CTG is pathological, but if the CTG is normal, we will not do any more FBS, isn't it?
If normal, there is no need to repeat blood sampling.
Okay, only if the CTG is going to be pathological continuously, then we will do it at the end of 1 hour.
Yes, if it's still pathological, you will repeat after 1 hour if blood sample is normal, or after 30 minutes of blood sample is borderline. But if CTG became normal, okay, there is no need to repeat. The advantage in CTG that once CTG is normal, this baby is 100% good. But if CTG is pathological, I can't depend. I have to confirm by scalp stimulation or blood sample. Okay?
Okay. Thank you.
Okay, thank you. Okay. This is a appearance of CTG paper. Okay, this is 1 centimeter. 1 centimeter. 1 centimeter. 1 centimeter. So from this vertical line to this vertical line, we have here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 centimeters. So each block of this, it's 10 centimeters. Usually, these 10 centimeters represent 10 minutes. So you have to look here. He will tell you 1 centimeter equal 1 minute. What if we are in a poor place and we have limited resources and we want to use less paper? We can adjust the CTG to make 1 centimeter equal 3 minutes. So 30-minute CTG will take 10 centimeter paper here and will take 30 centimeter paper here. So you have to look at what is the speed of CTG. Usually it will be 1 centimeter per minute. The numbers here, 60, 80, 100, 120, 40, 60, 80, 20. This represents the basal heart rate, fetal heart rate. Here 120, 140, so we can say the baseline. Okay, this line, you can see it represents the baseline. So the baseline is about 130 in this CTG. So number 1, what is the fetal heart rate? CTG. Here 130. Number 2, it's called beat to beat variability. What is the meaning of this? As you see, this line is not a smooth line, it's Soto's appearance, ups and downs. Why these ups and downs are present? They represent interaction between sympathetic and parasympathetic in this developing baby. In this developing baby, we need sympathetic and parasympathetic to be always in fighting with each other. Each one is trying to take the upper hand. because everyone is developing well. So sympathetic, parasympathetic, parasympathetic, para. This is good. This is healthy sign that the autonomic nervous system is developing well. So I need this sawtooth appearance. As you see, this is not a flat curve. There are small striations. I need this variability to be 5 to 25 beats. What is the meaning of this? For example, let's take this part, the difference between here and here, about 10 or 20 beat. Excellent beat-to-beat variability. And actually, we use looking by your eye. We will not measure. Look generally at the line. If you find that it's sawtooth appearance, so we have good variability. Okay, for example, in this one, it's not sawtooth appearance. It has low variability, reduced variability. And here variability is excessive. Excessive variability, reduced variability, both of them are unhealthy signs. I want variability to be intermediate, 5 to 25 beat per minute. Number 3, accelerations and decelerations. Okay, this is the beat-to-beat variability, and here this is acceleration, and here this is deceleration. Acceleration, transient increase in the basal heart rate. Deceleration, transient decrease in the basal heart rate. Any acceleration is healthy sign. Acceleration occurs when sympathetic acts. Sympathetic acts when the baby moves. So CTG with acceleration means this baby is moving, and this baby is has oxygen reserve to move. Fetal movement needs oxygen reserve. So fetal movement, if positive, indicates that this baby is not hypoxic and has good oxygen reserve. While deceleration, transient decrease in basal heart rate, it's not always pathological. There are types of decelerations. It can be early, it can be late, or it can be variable, or it can be deep prolonged, which is the worst one that this woman should be delivered. Early, late, and variable. What is the difference between them? Look here. Before saying the difference between early, late, variable, deep prolonged deceleration, we want to know how to assess uterine contractions. As you see here, this curve is representing uterine contractions, and you can find here that it's written TOCO. TOCO means contractions. This woman, for example, she has no labor pain, she is not in labor. What about if she is in labor? You will find that this woman is in labor. She has contractions. She has 2 contractions per 10 minutes. We said that this block, 10 minutes. She has 2 contractions per 10 minutes. If the deceleration is mirror image with the contraction, mirror image starting together, nadir and the summit together, the end together, synchronous mirror image. It's early deceleration. Early deceleration has no clinical significance. It's no problem to have early deceleration. Why? Because it represents compression over fetal head. With contraction, there is pressure over the fetal head. And this pressure will lead to parasympathetic stimulation. This parasympathetic stimulation will lead to decreased fetal heart, and this is early deceleration. What if you find that the deceleration is like this? Started after the contraction, the nadir is not synchronous with the apex, and even ended later. That's why I told you, when you do auscultation of fetal heart, auscultate just after the contraction. You may catch this sieve, the deceleration, the late deceleration. So late deceleration, it starts after and ends after the contraction. Frequent late deceleration is unhealthy sign. Another CTG, you can find some are early, some are late, and you can't know what is the type of this deceleration. It's called the variable. Sometimes early, sometimes late. It's called sometimes present, sometimes absent. It's called variable deceleration. So what is this? What is this?
Deep deceleration.
Prolonged deep
Bradycardia.
Hello?
Prolonged deep deceleration or prolonged deep bradycardia.
Hello?
Yes? Prolonged deep deceleration, which is very dangerous situation. Okay, if this baby died here, this occurred, these doctors, they have a great problem. 1 minute, 2, 3, 4, 5, 6, 7, 8. Why this baby was not delivered up till now? There was negligence. This baby should have been delivered by minute number 9. This baby was not delivered and died, so they have negligence. So compensations will be paid by NHS. And actually, in obstetrics, the commonest cause for our problems with law, it's called litigations. Our main problems are fetal hypoxia. That we didn't manage well fetal hypoxia. And the commonest cause for our problems is inability to diagnose pathological CTG. It's the most common cause for litigations. The second most common cause, we diagnosed that there is abnormality, but there was delayed management. Delayed management. Number 3, combination of both of them. So, CTG can be an evidence against the doctors that there was prolonged deep deceleration. How it persists more than 9 minutes and the baby was not delivered. Problem.
Hello, Dr.
Yes.
Osama.
Yes.
Yeah, doctor, where I am working, I don't know, it's everywhere. Maybe the commonest cause of, like we see this early deceleration pattern, we can say quite frequently, maybe 1 in 10 laboring patients, and the commonest cause is that the probe is starts to record the maternal pulse. So when I see a question like this, that there is prolonged deceleration, the first option that comes to my mind is adjust the probe. So I hope there won't be anything like this in the exam. I mean, if there is prolonged deceleration, it means it is true prolonged deceleration.
Yes.
Yes. In exam, I never saw any question relation to like technical difficulties. They go by clinical scenarios, actual clinical scenarios, not by technical faults. Till now, I didn't saw such question.
In CTG, you are not managing CTG. You are managing a full scenario, full case with CTG. That's why in this table, we will see that the presence of risk factors may affect your choice. The result of CTG, as we said, I look at the basal heart rate. I look at the beat-to-beat variability, which is appearance. And I will look at if there are decelerations. Accelerations are healthy sign, no problem. What is the normal baseline?
110 to 160.
The normal baseline from 110 to 160. Less than this, from 100 to 109, it's non-reassuring. And from 160 to 190, it's also non-reassuring. More than this or less than this, it will be abnormal. Less than 100 or more than 180, it's abnormal CTG. So when you look at the baseline heart rate, I want it to be 110 to 160. The baseline variability, I want Soto's appearance like this, and I want the difference to be between 5 to 25 beats. If more than this, it will be increased variability. Less than this, it will be reduced variability. If less than 5, for 30 to 50 minutes, it's non-reassuring CTG. If this low variability became more than 50 minutes, it will be abnormal CTG. So less than 5, up to 50 minutes, from 30 to 50, non-reassuring. Prolonged more than 50 minutes, it will be abnormal CTG. What if less than 5 for 10, 20 minutes? No problem, no problem. As long as less than 30 minutes, no problem. It's still reassuring. Also, increased variability is unhealthy sign. If more than 25, up to 25 minutes. If more than 25, it will be pathological. So more than 25 beat-to-beat variability, more than 25 minutes, it will be abnormal CTG. It's very easy now for basal heart rate and for variability. Basal heart rate 110, 160. 161, 190, non-reassuring. 100 to 109, non-reassuring. Less than this or more than that, it will be abnormal. Variability, I need 5 to 25 beat per minute. If less than 5, from 30 to 50, non-reassuring. More than 50, abnormal. More than 25, up to 25, non-reassuring. More than 25 beat, more than 25-minute pathological. Okay, any difficulty in baseline heart rate or in variability?
No.
You are professional, Dr. Fawzi. I am asking something else.
Sorry.
Something else? Is there any difficulty? No difficulty? معقول؟
No, doctor.
Okay. دكتور صديقة. دكتور صديقة.
Hello, yes, sir.
Easy up to now.
Sir, the beat to beat variability, how do we calculate? I'm getting confused about that.
Why you didn't ask? Don't be shy to ask if something is not clear. Okay? You have the right to ask. Okay? Look,
Yes, sir.
Look here, Dr. Sadiq.
Yes.
For example, can we take this part? Measure the difference between the highest point and the lowest point. Okay? Here 120, 130, 140. Here the difference is about 10 beats. So it's between 5 and 25. Yes, excellent. Okay, you can take any point. You can take this point. Also, difference is more than 10, about 15. Excellent. Take this point. Also, between 5 and 25. Excellent. This is an acceleration. Don't you? This is acceleration. It's a good sign. So, from the CTG, Dr. Sadiq, what is the basal heart rate? Sadiqa?
Yes, sir. Yes, doctor.
What is the basal heart rate?
Sir, sorry, sir, you're not clear.
The basal heart rate. I will show
It is 110 to 160.
One what?
Okay, here it is around 130.
130. Excellent. We can see this line is representing 130. Excellent. What about variability? Good or reduced or increased?
It is good, doctor.
We have photos appearance, not near flat and not exaggerated, isn't it?
Yes, doctor.
Do you find accelerations, transient increase in heart rate and then return it again to normal? Acceleration. Look at this one.
Yes, doctor.
This is transient tachycardia and return it to basal heart rate. It's called acceleration. Also, this one, acceleration. This one, acceleration. The presence of acceleration is a healthy sign. This baby has good oxygen reserve. Do you find any deceleration?
No, doctor. Just.
You are right. There are no decelerations. This woman is in labor or not?
No, doctor.
Not in labor, no contractions. So, your final comment, this is normal CTG. We have accelerations, good heart rate, good variability, no decelerations, and no contractions. So, this woman, normal CTG, and she is not in labor.
Okay. Yes, doctor. Yes, doctor.
Okay, excellent. Thank you. Thanks, Sadiq.
Yeah, thank you so much, doctor. I understood very nicely. Thank you.
Thank you. You will solve more and more today.
Okay, doctor.
Okay. Thank you.
Thank you.
Okay, so let's take the remaining part, which has some details. In this table, you will find that this one is green, and this one is green, red, and red. I mean by these colors that this one is exaggeration of this one. And this red one is exaggeration of this one. Exaggeration in what? In time. It became more prolonged. More prolonged, so it will be shifted from non-reassuring to become abnormal. Or it will affect more contractions. Affect more contractions. What is the meaning of this? Look here. If we look at, this is the toko, one contraction, 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 contraction. How many contractions here? How many contractions?
7.
7.
7 contractions. Okay, here's the fetal heart. What is this? What I brought down? What is this?
Variability.
Variability. Excellent. Not like this. Is it mirror image or not?
Yes.
Mirror image. The nadir in front of apex started together, ended together. Which type of deceleration is it?
Early.
Early deceleration.
Early. Excellent. And look here. There is variability. What do you think about this one? Mirror image?
Late.
No, not mirror image. Here.
Late deceleration.
And here nadir. Late deceleration.
Loss of variability.
What about this one?
Decreased variability.
Early or late? This one?
This late.
Late. How many variabilities are present? Sorry, how many decelerations are present?
3 decelerations.
3. How many contractions are present?
7.
7. Three in relation to 7. Is it more than 40% or less than 40%?
Less than.
Less than. So this is what we mean by variability decelerations less than 50% of contractions. What if we had 4 decelerations here? Is it more than 50% or less than 50% of contractions?
More.
More than 50%.
More. So we count the contractions, we count the decelerations, and we see is it more than 50% or less than 50%. Okay? What do you want from decelerations? I don't want decelerations at all. But there is one type of deceleration which is a healthy one. It's physiological. It's due to contractions pushing over the fetal head. What type of deceleration is it?
Early.
Early. What is its cause?
Head compression.
Leading to?
Parasympathetic stimulation.
Vagal stimulation. Excellent. So, can it be present without contractions?
No.
No. What if you find decelerations without contraction? Is it a benign one or malignant one? Malignant, not physiological. Early is present only with contractions. If no contractions and you find decelerations, we are now talking about not healthy sign. Okay. So I accept that there are no decelerations. Excellent. Early accepted, physiological, no problem at all. Variable, sometimes early, sometimes late, variable decelerations with no concerning characteristics. What do you mean? We can remove this word to say with no bad characteristics. We have some characteristics which can be present in the deceleration wave itself, by which if you look at this deceleration, you say it looks a bad one. Or you look at it, you say it looks a not bad one. Bad behavior or good behavior of the deceleration itself. Let's at first know what are these characteristics. If these characteristics, concerning characteristics are present, it's a bad sign. What are they? Imagine that the deceleration persisted more than 1 minute. Bad sign. Bad sign. If the deceleration itself, it has reduced variability inside. So if you have deceleration with good variability inside it, it's a good sign. But smooth line like this one, it's a bad sign. So you can say that presence of variability inside the decelerations, the deceleration is saying to I am sorry, don't be afraid, I am a good one. Failure to return to baseline. Look at this deceleration. It returned to a baseline less than the normal one. It's a bad sign. Biphasic. Not only deceleration, the deceleration is playing. W-shaped. You know, she wants to make you angry. Look, I am not only deceleration, I am playing while doing deceleration. This is a bad one. Annoying deceleration. Absence of shouldering. We said that here, if the deceleration has good variability, she is saying, I am sorry. Also, if the deceleration showed acceleration before and acceleration after, she is saying, I am sorry. So this is good sign. This is good sign. If the deceleration is more than 1 minute, with poor variability inside, playing, biphasic, annoying one, no shouldering, so not saying even I am sorry. The deceleration knows that I love acceleration. So please show me some acceleration before and after. Show me some variability. If you didn't do, you are a bad one. So these are the 5 bad signs. If you find them, this variability is an annoying one. Again, prolonged more than a minute with poor variability inside, no shouldering. Shouldering is acceleration after and before. Here, she is saying to you, I am sorry. If she didn't say I am sorry, she is a bad one. And this one, biphasic, also is a bad one. Okay? Any one of them is not easy. دكتور صديقة؟ صديقة؟ So these are the bad signs. I don't want to see them in the variability, in the deceleration. So if you find variable decelerations without these ugly signs, up to 90 minutes, no problem. So variable deceleration, less than 90 minutes, and they don't have the bad signs, I accept them. And I accept this CTG to be normal one. So what if more than 90 minutes? It will be non-reassuring. What if they had bad signs concerning characteristics up to 50% of contractions, more than 30 minutes, non-reassuring, or less than 30 minutes, but more than 50%. As you see, I make one worse and the other better, or vice versa. So more than 50%, less than 30 minutes, or less than 30 minutes, but more than 50%. Both of them are non-reassuring. So I can expect, if more than 30 minutes, more than 50%, it will be pathological. If I added these ones together, they will lead to an abnormal CTG. We finished variable decelerations. What about late decelerations? Late deceleration, more than 50% of contractions, but less than 30 minutes. This is good. So if more than 30 minutes, it will be pathological. So late deceleration, more than 50% of contractions, more than 30 minutes, more than 30 minutes, pathological. Less than 30 minutes, non-reassuring. Okay, if you read them once or twice, you will find that they are easy, and you will find that abnormal CTG is an exaggeration of non-reassuring one. That's why we care for what is the duration of this abnormality. If small duration, non-reassuring. Long duration, it became abnormal.
Dr. Osama?
Yes.
We are interpreting this CTG in a 90-minute trace, isn't it?
Interpreting what?
In a 90-minute trace.
90-minute trace. According to, for example, if you find that there are late decelerations, more than 30 minutes, more than 50% of contractions, it's finished. This is abnormal CTG. I will not wait more than this. Okay, for example, if you find this one finished, there is no need to wait for 90 minutes. You need to wait more. Here, I will consider this CTG to be a pathological CTG. I will put the woman on left lateral position. I will stop or reduce oxytocin. I will give fluids if dehydrated. I will give paracetamol if feverish. And I will ask for doing tactile scalp stimulation. If there are accelerations with the scalp stimulation, okay. If no acceleration, go for fetal.
Dr. Osama, the only difference between non-reassuring and abnormal feature of a late deceleration is that both of them are there for 50% of the contraction, but the only thing is that less than 30 minutes and more than 30 minutes.
Yes.
I see.
This is a difference between the two red ones.
between the two reds. Yeah.
Less than 30
And,
minutes, more than 30.
and another important difference is the presence of risk factor actually,
Sure.
which is limitizing. If 30 minutes without risk factors, less than 30 minutes with risk factor.
Excellent. Also, presence of risk factors. Also, other problems like prolonged deep deceleration. I will not wait for 30 or even 5 minutes. I will diagnose that there is prolonged deep deceleration just after 3 minutes. Okay, so you will look
like lead deceleration with the bleeding or with grade 2 meconium, so you will not wait for even 30 minutes for even
if what?
If late decelerations with bleeding, heavy bleeding, or with the grade 2 meconium, 3 meconium, then you can take the decision before 30 minutes. You will not wait for
bleeding according to severity of bleeding. If bleeding is mild.
Yeah, but high risk factors are what? That is the bleeding and meconium.
Bleeding is an indication for CTG, but severe bleeding is an indication for delivery. Okay, but mild bleeding, I will apply CTG and I will wait for the result as long as
when we talk about risk factors, or what are the risk factors which we will correlate with the late deceleration?
If you suspect that there is placental abruption and you have rigid abdomen, are you going to wait for these minutes? No, I will not wait.
This is what I'm saying. Risk factors means IUGR or hypertension or diabetes like this, or just at the time of labor.
All of them are indications.
All of them.
Yeah,
all of them.
If we are monitoring SGA fetus, then we'll have to see that also.
Look, if we return here again, okay, all these are risk factors and all are indications for CTG. If you find
like in style of VBAC, will not wait. That is the first indication of uterine rupture.
If you find with these ones, there is non-reassuring CTG, it will be more significant than if these risk factors are not present. So, as I said, we are not treating a CTG. You are treating a woman with CTG. So, to summarize, the baseline 110 to 160. Normal 110, 160. 100, 109, non-reassuring. 160, 190, non-reassuring. More than this, less than this, abnormal. We said what are the concerning characters. Somebody can tell me some bad characters of variable deceleration?
If there is no variability and there is no shouldering.
Variability inside the deceleration. What else?
No shouldering.
There's no shouldering.
No shouldering. Like this one. I want shouldering to be present. No shouldering. Excellent.
We want shouldering to be present.
Last for more than 1 minute.
More than 1 minute. Excellent.
More than 3 minutes.
Then failure to return to the baseline.
Failure to return to the baseline.
Biphasic. And if it's biphasic.
We can say that this one has all concerning characteristics. More than 1 minute, no shouldering, W-shaped, biphasic, and no variability, and failed to return to the baseline. So this is the most dirty, most dirty variability, most dirty deceleration ever. W-shaped, no shouldering, no variability, and failed to return to the baseline. So this is the worst variability ever.
Dr. Osama, what is sinusoidal pattern?
What is what?
Sinusoidal.
It will come now. Sinusoidal is a form of exaggerated variability, as you see. This is normal variability. But what about this?
Okay.
Exaggerated one, and this is poor sign.
Okay, thank you.
It denotes fetal hypoxia. So at last,
Fetal anemia. Fetal anemia.
Fetal anemia, okay. Fetal anemia. So at last, the result of CTG the result of CTG will be either normal, so everything is okay 100%. Suspicious, 1 non-reassuring, 1. Hey, please check your mics. So, suspicious, 1 non-reassuring, pathological, 1 abnormal, or 2 non-reassuring. So if we return here, everything is okay. This is normal CTG. If we have 1 non-reassuring characters, it will be non-reassuring CTG or suspicious CTG. If we have, for example, reduced variability, and also we have variable deceleration with no concerning characteristics. Now we have 2 non-reassuring sign. 2 non-reassuring sign, it will be pathological CTG. Any combination of 2. For example, this one, and this one, this one, and this one. Any combination of 2 non-reassuring signs, it will be pathological CTG. So everything is normal, normal CTG. 1 non-reassuring sign, suspicious. 2 non-reassuring signs, or 1 pathological sign, it will be pathological. In suspicious and pathological, we will do expectant measures. Left lateral positions, fluid if needed, antibiotic if needed, slow oxytocin if needed. In pathological also, I will do scalp stimulation. If no accelerations occurred, fetal blood sample. If prolonged deep deceleration, exhibited birth. Exhibited birth. Exclude cord prolapse, exclude abruption, exclude rupture uterus, correct underlying cause. They are conservative measures. Okay, as you see here, this is a basal heart. Bradycardia, persistent. And as you see here, we have 3 minutes. This baby should be delivered immediately because here we diagnosed prolonged deep deceleration. What I am going to do, seek obstetric help, expectant measures, conservative measures, expected birth if persisted up to 9 minutes. If recovered before this, okay. So we return it again to normal. But if persistent up to 9 minutes, this baby should be delivered. Instrumental if possible. If not possible, cesarean section. Conservative measures, again, left lateral position, fluids, reduce contractions by either reducing oxytocin or even giving tocolytic like terbutaline 0.25 milligram, antipyretic if feverish. For what duration the hospital should keep the CTG? We keep obstetric data for 25 years, but take care if, for example, the situation of fetal hypoxia and labor dystocia, difficult labor, these files should be kept more than 25 years. because maybe when this baby grows up, okay, we find that this baby has TB or this baby has abnormality. So we have to keep files of bad labor indefinitely, more than 25 years. But if just normal labor and the case is low risk, the file will be kept 25 years. So can you tell me if after delivery, okay, the child grows up and didn't find a good wife to marry, the file should be kept 25 years or more? What do you think?
25.
25? Are you afraid?
Wife has nothing to do.
You have doubts?
There is no relation of getting.
You have doubts? As we said, if you find the pathological CTG, do scalp stimulation by your finger. If acceleration occurred, excellent. No accelerations, this baby needs more concern. We will do fetal blood sampling. Okay, I think we will take a break for praying al-Jum'ah.